Thank you everyone for attending this meeting by the Centre for Risk Analysis. Here we will be having data scientist Ian McGorian from Pandemic Data and Analysis, PANDA, to come to talk to us about potential second wave fears in South Africa. Obviously, this is something the government has mentioned before. This is something we've seen in a lot of Western European nations, and I think it's very useful to take a deep dive and take a good look at the data beyond what has been said on the headlines. Just a few housekeeping rules. If you have any questions, please write them in the Q&A section. Ian will give his presentation, and then following that, I will curate a few questions and refer them to Ian. In addition to that, we're going to have a question which we'll ask at the beginning. We're going to conduct a poll. Sharon, could you please bring up the poll now? And if you see that poll come up on your screen, we're just interested to hear your opinion, and we'll conduct the same poll at the end. So the polling question is, of course, do you think that concerns about a second wave of infections in South Africa are justified? I don't see anyone else voting, so I'll read out the result. Sharon, you can end the polling. So the results are 58% say yes and 42% say no. We'll see if anybody changes their mind by the end of this presentation. Thank you very much. And without further ado, I will hand over to Ian McGorian from PANDA. Ian, over to you.
Hi, thanks very much for having me on. So the talk about second wave, I'm going to share some data with you. Obviously, I'd be available to answer questions at the end, but let's get right into it because there's a fair amount that I have to get through. So the first thing is that if we look at Europe in total, there's no doubt that there's a second wave of infections. So on the left there, April was the peak of the first wave, and on the right-hand side, you can see where we stand at the moment. So it is significant, and obviously the news outlets are really blowing this up, and they are creating a lot of noise around it. And this is the graph that you would typically see on any of your news channels. The graph that you don't see is the death graph. And the death graph for Europe looks like that. So you had your absolute peak of deaths in April. And yes, it is fair to say we've had a second surge in deaths, but nowhere near the magnitude that we had in the first wave. And surely the metric by which you measure a viral outbreak must be the consequence of the viral outbreak. And the consequence would be your resources in terms of hospital bed usage, ICU bed usage, health service utilization, and obviously the dread deaths. Now, in order to describe this properly, I want to take you through various parts of Europe just to illustrate exactly what I mean by this second wave being, should we say, overwrought in terms of consequence. So if we start with Northern Europe, I know it's a busy graph, but it's important for me to explain what I'm trying to show you. These are two different scales. So the cases scale is different to the death scale. I've done that deliberately to show you graphically how this works. The dark blue line here is the case fatality rate. So it's a very crude measure, but it's how many confirmed cases have you got and what is the death ratio to those confirmed cases. So what you can see here, Northern Europe, first wave, lots of deaths. Second wave, lots of cases, very little death. And the case fatality rate, the CFR has dropped from a high of 17.1. It has held steady at 0.5 now for the last 2 months. Southern Europe, the same thing. Excuse that little blip there. That's when suddenly we had people coming back alive because the statistics officers had made mistakes in some parts of Europe, UK, Spain, etc. However, same thing applies. Cases in the first wave, deaths in the first wave, much more cases in the second wave, very few deaths. Western Europe, exactly the same picture. First wave cases, first wave deaths. second wave cases, second wave deaths. Case fatality rate, Western Europe is down from 20.2 also down to 0.6, 0.3, 0.4 for the last 2 months, 7-day rolling average. So what has contributed to the deaths in Europe is Eastern Europe. Eastern Europe is clearly on an upward incline in deaths, exponentiating, but Eastern Europe is essentially in their first wave. So looking at Europe as a whole is a little bit deceptive. If you take Europe excluding Eastern Europe, this is the full picture. So that's first wave cases, first wave deaths, second wave cases, second wave deaths. Now, it's very easy for me to argue that this is nowhere near as severe as the first round. Equally, throughout the rest of Europe, we've gone down from a 16.6 high case fatality ratio down to where we are currently at a 0.5. So what are the dynamics at play here? There are quite a few dynamics at play. The first is that it is true to say that cases have doubled. First wave, 33,000 per day, current 60,000 per day in Europe. But what has also happened is that testing has ramped up in this period significantly. So where we were doing 140,000 tests a day, we now are hovering around here at close to 1 million tests per day. So the testing itself has increased 8-fold. Now, I'm not saying that the things are linear, but if you increase the amount of tests that you do by a substantial amount, of course, you're going to have more positive tests. That's a logical progression. And what we're talking about here is an 8 times increase in tests, but only a doubling of the cases. So that tells you that the positivity rate in Europe has dropped off significantly since the first wave. Northern America, arguably going through a third wave. So there's first wave, New York, Northeastern America, second wave, third wave. But looking at America as if it's, treating America as one country, given the geographical size of America, is actually very difficult to do. And you can see that empirically by looking at things like the Hope-Simpson chart of how flu spreads through America and how absolutely seasonal it is and the path that it takes through America. So I think to demonstrate this, yeah, come on.
Is everything all right on that side?
I can't seem to get that. No, I can't get this to work. Oh dear. Okay, moving on. This is just a visual that shows how the virus is spread through America, starting in the Northeast, moving to the Southeast shortly after the New York peak, moving across to California, Florida, etc. And now, currently, the third wave is now concentrated in the Midwest. So the mantra that we live with is test, test, test. And my mouse has died completely.
Have you got a trackpad? Would you like me to share my screen, or do you think you can continue there?
Share yours.
Okay.
Actually, something's gone wrong here. Sorry.
Give me 1 sec. All right. Just remind me, what slide are we on? We're on the one with Tedros.
Yeah. All right. So the mantra at the moment from Tedros, etc., is test, test, test. But let's talk about the PCR test. It was originally developed in the 1990s. Kary Mullis, the inventor, was awarded the Nobel Prize for it in 1993. And it is essentially a manufacturing device. It is designed to make billions of copies of a specific DNA sample in order to make that sample large enough to study. The inventor of the PCR said that it would have enormous use and really good use in medical research and forensic pathology. But he stated over and again that it should never, ever be used for disease diagnosis. And that comes as something as a surprise, given that we are using PCR tests worldwide. So let's just have a look at a few facts about PCR tests. If you can go to the next slide.
Can you see it there? Can you see it there?
Doesn't come up yet.
The bar graph with blue bars. Can you not see it?
No.
Apologies. Not sure what's going on. Still nothing.
No, but I will talk to. No, I'm just seeing. I'm not seeing your screen at all. I'm seeing the previous graph.
Okay, let me.
Okay, let me talk through on my side.
Continue speaking. I'll see if I can reshare it and see what happens. Apologies for this.
All right, so let's look at the pattern in South Africa. To date, we have conducted 4.4 million tests in the country. If you take that out at an average of plus minus 900 Rand a test, we've spent 3.9 billion Rand testing people. Remember that through a large portion of this whole event, we were testing people that we were sure were sick. We were testing people that were presenting with symptoms, etc., etc. We have a selection bias problem in South Africa in that approximately half of the tests are done by the public service and half of the tests are done by the private service. Now, why I say selection bias, if a private individual goes for a test, they pay for it. Public, you have to be really shown to have the symptoms before you get tested. Be that as it may, it's safe to say that the majority of these tests were performed on people who were showing symptoms or who thought that they had COVID or had been exposed to COVID-19. Of the 4.4 million tests that we've done so far, 703,000 have been positive. So 16% of the tests that have been conducted have tests for SARS-CoV-2 have tested positive. Of those 703 positives that we have had in this country, only 86,000 people have required hospital admission. So this entirely tracks what happens in the world, in that a positive case does not necessarily mean the disease. And this is an important, an extremely important thing to understand. SARS-CoV-2 is the virus. COVID-19 is the expression of the virus as a disease. And what we know from worldwide, all the data worldwide, and I can show it to you for any country that you like, the expression of the disease from a positive test is very, very low. And the actual hospitalization or the need for hospitalization is an extremely low proportion of the people who test positive. The vast majority of people are simply asymptomatic. They don't have any signs of the illness at all. You have a large portion of people who are mildly symptomatic. In other words, it expresses as a flu-like illness, but it requires simple stay at home, do the sensible stuff, and you're back on your feet within 10 to 12 days. But some people do require hospitalization. In our case, 86,000 people have been hospitalized so far, which is a rate of 12% hospitalization. Of those hospitalizations, 21% have died, and that is our current death stat, 18,471. So 2.6% of positive cases have passed away from coronavirus. If we look at worldwide, we've done 502 million tests so far of the countries that report on their testing at a cost of approximately 452 billion rand. Of those tested worldwide so far, 0.2% have died. Can we move to the next slide? So let's talk about polymerase chain reaction cycling. So the PCR test is a test that is cycled, and every cycle doubles the magnification of the initial strand of RNA, which then becomes a DNA strand that they then amplify. And with each cycle that you do in a PCR, you're doubling the amplification of the viral thread. To give you an idea of what that means, after 20 amplifications, you have 1 million copies of the original DNA. After 25 cycles, you now have 33 million. You've amplified the original thread by 33 million. After 30 cycles, you have 1 billion copies. After 34 cycles, 17 billion copies, and after 35 cycles, 34 billion copies. So this is, it is orders of magnitude what you're doing, and there is so much controversy now about the CT cycling, because what we're seeing in the literature, there are papers coming out thick and fast now about cycling this many times that you're not picking up live virus, you're picking up relics of dead virus or virus in such tiny loads that it's not going to result in a sickness. So yes, lots of tests, but the result of these tests, these positive tests, is not the concomitant illness, hospitalization, or death. An interesting little anecdote: when the NFL restarted their season in America, they had to postpone games, they had to reschedule games because they were getting positive tests. They then changed their strategy quite quietly, but they have now stopped the cycling at 20. So although the players are being tested every day, the tier 1 players in NFL are being tested every day, they stopped the PCR testing at 20 cycles, which is 1 million copies. And there is a growing body that says anything more than 25 cycles on a PCR is not actually telling you anything. So one of my pieces of advice is, should you ever get a PCR test that is positive, ask at which threshold it was shown to be positive. That'll give you a pretty good idea of the viral load in that positive test. Viral culture is regarded as the gold standard by which you can reference or test. You can reference your test or benchmark your test results again. Now, I'm not saying it hasn't been done, but it is quite interesting that if you do a Google Scholar search for successful purified viral culture, you'll see that it has only been successfully done a handful of times. So it's almost as if the test is being calibrated against the test, not against the virus, which is very unusual. I think it's also unusual that there are various assays out there. Labs develop their own assays, there are commercial assays, and these are the assays that are used in these PCR tests. And the WHO did an interesting thing a month and a half to 2 months ago. They recommended that the assay to be used is an assay that recognizes all coronaviruses, not just COVID-19. So that's a pretty strange way of going about this in and of itself. And you would think by now, given that we are 8 months into the disease and 8 months into testing all of those people and at the expense of all of that money, that there would be a global standard for CT cycles. Surely, we should be able to, because it's a continuum. At what point do you say a test is negative or a test is positive? It's certainly not clear in any of the literature where that threshold value should be and where the cycles should stop. Again, Kerry Mullis was famous for saying that if you are testing at more than 30 cycles, then there's something wrong with your PCR. He's the inventor of the process. So why don't we have a global standard for CT cycles, a global standard for assays that get used and in what sequence they get used, and that the reporting of these metrics should be demanded. I mean, I would challenge any of you to try and establish how the government lab in South Africa, how many cycles they're going through, because believe me, we've tried and we can't get to that information. So we have moving on from the PCR test, we have a second issue that is going on, and that is that a lot of the stuff that we have done in this country and the stuff that has been done around the world has been based on SIR or SEIR models. And PANDA has spent a great deal of time and effort in showing these models and what we think of them and how we criticize them has obviously had wide coverage. But I just want to do a quick reality check. These are the two official government models. The blue line is their optimistic model and the red line is their pessimistic model. The black line is the actual deaths that have occurred up till yesterday. So you can see that these models are not out by a couple of thousand, they're out by orders of magnitude. It's actually becoming a little bit, it has been from the beginning, but it's becoming more and more distressing that the government continues to talk about 40,000 to 50,000 deaths, which is the official model. If you look at this graph, we should have been there already. We are nowhere close to that. We are unlikely to get close to that. You can see that our death results are dropping off dramatically every day. But these models do another thing. They drive resource allocation. So if we take the American example, they had USS Mercy parked outside New York Harbor throughout the crisis. It left New York Harbor having treated 175 patients. XL London, 51 patients before they closed it down. The Florence Nightingale Hospital that was set up at XL, the Javits Center in America was closed down, having seen just about plus minus 1,000 patients. Now, I've got my numbers from DATCOV. I do recognize that there have been other numbers thrown around, but just consider this: Nasrec, 1,500 beds, and it had a total of 501 admissions. Cape Town Convention Center, 800 beds, 471 admissions through the whole thing before they got closed down. So if you take Nasrec as a simple example, at the 1,500 beds, 501 admissions, it cost 350 million Rand, Nasrec. So that's 680,000 Rand per patient treated there. Looking at the 1,400 field hospitals that were contemplated by government, for the data that we have scraped, and we've scraped on 591 all hospitals, field and outside, etc., district in general, we see in the field hospital that there was a utilization of less than 9%, which is pretty scary. It's been a massive waste of money and resource and time, and just a harbinger of fear. To put that in perspective, the government model for hospital beds and intensive care beds, there you see the blue line again is the optimistic, the red line the pessimistic, and the black line at the bottom is the actual utilization. So you can see that for beds, it was overstated by 18 times. The optimistic view was overstated by 14 times. We're not talking small mistakes here. We're talking about, consider this, in total, there have been 86,178 admissions into hospital, total admissions. These models are talking about 80,000 admissions in one day. We haven't even got there in the entire time. That's what we mean about gross. The modeling has been grossly wrong. So second wave, well, coronaviruses are seasonal. Every other coronavirus has proven to be seasonal. So why wouldn't we expect that from this one? It would be astonishing if it wasn't. The first wave has shown probably the dry tinder effect. And the dry tinder effect is maybe not a pleasant term, but it simply says that those people who were susceptible and who were likely to have a bad outcome from contracting corona, well, it's gone through and they've either been hospitalized or they haven't recovered. We know that that coronaviruses do not mutate very quickly, and this one in particular is not showing itself to mutate very quickly. So there's no reason not to see it as what else could explain it. So our contention is that, yes, we do need a reset, and there's no doubt about that, but the only reset that is really required is one for some critical thinking and some rational risk assessment. And, you know, let's really start being clever about what are we dealing with and how are we dealing with it, and what damage are we causing in the process of dealing with it. All right, there's my 25 minutes. Thank you very much for your time, and I'm very happy to take questions.
Thank you very much for that, Ian. We'll start off. I see there's just one question here, just about the one slide that you had on. Does the slide showing the inaccurate modeling, the first one that you showed with the blue, the red, and the black lines, David, could you perhaps scroll back to that one? Does it use SA's official COVID death rate or the excess death data? That one.
That one, yes. Okay, so this is the official COVID deaths. The excess death number that is being tossed around, I can point you in the direction of a number of questions that we have raised about how excess deaths are being calculated.
I've actually got a question here about excess deaths. Can I ask that quickly, and I'll let you then explain the whole thing?
Sure.
So the question is, in Europe, how much of the lower death rate relative to infection rate may be attributable to better preparedness by hospitals, a better understanding of effective treating methods like therapeutics, versus a potential level of semi-herd immunity being built up in the region post the first wave? So that's the question about excess deaths.
So you'd have to read that again about the excess deaths. I understand that question slightly differently to you.
Oh, sorry, apologies. I was thinking of the one before, but let's ask this one. So in Europe, how much of the lower death rate relative to infection rate may be attributable to better preparedness by hospitals, a better understanding of the effective treating methods versus a potential level of semi-herd immunity being built up in the region after the first wave?
Okay, so I absolutely agree with you. We have learned a lot. We've certainly learned that ventilators are not all that they're cracked up to be. We have learned that high flow nasal oxygen is an early application of it. The drug cocktails that are being used have been improved tremendously. I have no doubt that we are being that worldwide the outcomes are better. However, they are not better by the magnitude of difference that we are seeing. In other words, they would contribute to a percentage, and let's call it maybe a 10 or a 15% contribution to the outcome. But there's no way that the medical change or the intervention change has been of such an order of magnitude to describe how different the second wave is compared to the first wave. It's simply, yes, it contributes, but not, it goes no way to explain this dramatic difference.
So here's the question about excess deaths. Apologies, I read them earlier and I mixed them up in my mind. The question is, given the excess deaths in the order of 40,000, are we not undercounting the number of deaths where COVID was present? Not saying that the death rate is alarming, i.e. even with higher deaths still towards the lower end of government and other forecast ranges, but a more realistic number could be around 30 to 35,000 and not 18,000. So the question there just about the number of people who have died, obviously versus last year. Any comments on that one?
Yeah, certainly. I mean, we have been challenging this excess death narrative right from the beginning. But let me give you 2 points about the excess deaths that are being reported. Number one, excess death is a normal calculation that you do in any country in the world, and it's simply take the average of the last 5 years, project and adjust for population size and adjust for various other things, but essentially that you get a baseline of predicted deaths, right? And then you compare this year, your total deaths to that predicted deaths, and that tells you your excess deaths. So it's a simple calculation. Total deaths this year, less total deaths last year. What we're doing, and it is very simple to show you this, and it's very simple for you to go and see it for yourself, is in this country, in that number, every single COVID death is being treated as an excess death. Every single one. Now, it is beyond preposterous to say that every single person who has died of COVID is an excess death. It doesn't gel. It's a complete change to the way that excess deaths are calculated anywhere else in the world. And as far as I'm concerned, it's slightly scandalous. Secondly, if you go and have a look at the graphs, and if you have a look at the calculations, and we've rebuilt the calculations to prove the point, and I could talk about this subject for an hour, but if you just go back through the literature, you'll see that excess deaths were being calculated not off the predicted line and not off the predicted data, they were being predicted off of the lower bound. And that lower bound prediction baked in a new way of doing things, which is readily admitted to in the paper, where what they said is, we're not only taking the deaths that we know about, but we're making an estimate of how many people are dying. We're making an estimate. So, I'm sorry, but that estimate was 7,000 bodies. 7,000 bodies. So we've got 18,000 COVID deaths sitting in there. We've got 7,000 estimated bodies that where they come from, I have no idea. That's all baked into this 40,000 number. This whole journey on excess death has been an exercise in frustration at our medical fraternity and what they're doing and what they're trying to show.
Just got a question here about the testing. Is the relative low number of cases in China and Korea then a result of different number of cycles run of the tests to give a positive?
there's no doubt that it's not only different cycles, it's different assays. So the sensitivity of the tests, for example, the sensitivity of the Russian test is 1/10 the sensitivity of the American test. So you take any Russian confirmed number and just multiply it by 10 if you want to match it to America. And that's the point I'm trying to make about this PCR testing, why it is so difficult. It's different from manufacturer to manufacturer. So, so any kind of comparisons, in other words, confirmed cases have almost become meaningless. They pretty much have become meaningless. And to give you an example, the first country that has really cottoned onto this is Belgium. You know, Belgium was one of the worst hit countries in the world. And when they saw the second wave coming, they obviously started to panic a bit. However, sensible heads have prevailed, and Belgium is no longer using cases as a metric. They are purely using hospital admissions as a metric to measure the effect of the disease in Belgium. And that's now official policy, because the positive cases have become pretty much, you know, it's as wide as a barn door.
I've got one more about the PCR cycles. The question is, if a higher number of PCR cycles is responsible for giving false positives, doesn't that mean that the mortality is arguably higher, even though the total number of cases is overstated?
Just say that again.
If a higher number of PCR cycles is responsible for giving more false positives, so I assume what is meant by that is that you end up detecting the virus even in a very, very small load. And then the question follows, doesn't that mean that the mortality is arguably higher, even though the total number of cases is overstated? So if I follow that question correctly, it's saying that you could perhaps have a very small viral load and still die. I'm not quite sure I understand that question. Perhaps if you'd like to just elaborate in the comments, who asked that question.
I think what the question is saying, which I happen to agree with, but there are some caveats here. In other words, we are getting lots of false positives, right? Or positives that are not necessarily leading to disease, leading to expression of the disease. We measure case fatality ratios. You can infer an infection fatality ratio. In the case of COVID-19, it's almost impossible to infer an infection fatality ratio because of the reasons that I've described to you up to now. But by whichever measure you look at it, by whichever measure, it is by orders of magnitude lower than the modelers predicted and are still claiming for. They still hang their hats on these models that have been proved around the world to be disastrously wrong.
A question here, I haven't personally heard about this statistic, but perhaps you have, Ian. Discovery Health claims that 90% of excess deaths are from COVID and that the total number of deaths is in the region of, is that 45,000? Are they right? I personally haven't heard of that number. Do you know what he's referring to?
I do, certainly. And we have directly challenged Discovery on that assertion, and we have asked them to give us the detail and the data that is driving an assertion like that. They have refused to comply. This is almost a standard. This is almost a standard subset. So what happens is Sakima comes out with a model. We ask them to engage about the model. Eventually, you've got to launch a PIA application. A PIA application takes 30 days. Then they come back and divert you in this way and that way. So we've been launching PIAs at everyone throughout this whole thing. We are we are vaguely interested in launching a PIA against discovery, because that is quite an astonishing claim to make. And you'd have to have the data, you'd have to have a lot of data that is very different to all of the government data, So we Medical Research Council, NICD, et cetera, aren't showing anywhere near those numbers or close to those numbers. So where do we get them? To attribute 90% of excess deaths to COVID, that's an interesting move. That's a very interesting move, because I'm sure you're aware that Department of Home Affairs is responsible for the death certificate, the collation of the death certificates. What the NICD receives is a ID number, a date of death, and was the death natural or unnatural. They don't receive any information about the actual cause of death. That sits at Home Affairs. The last time Home Affairs managed to reconcile cause of death was in 2017. So how could anyone in this country be able to attribute 90% of those deaths to COVID?
I think moving on from this, there's a question here. Could you please elaborate on what is the best measure for comparative purposes? Is it hospitalized cases? And is there any consensus on this? So, I mean, what is a good measure in actuality to try and estimate where we are within an epidemic?
Well, I would say that hospitalization is a fundamentally good measure, because I mean, isn't it the most sensible measure of all? Because everything about this is resource utilization. Everything about the response. In fact, the whole initial lockdown of 21 days was about getting the healthcare services ready. So surely it's an eminently sensible thing to measure hospitalization as a metric of where you are in terms of your curve. Makes sense to me.
That seems very intuitive to me as well. I've got two questions here. So the first is, have any studies looked at the mortality rate of COVID in a population group as a whole, i.e. not just individuals, the symptoms? And then there's another one. Can you please revisit the death rates / how South Africa compares globally, and explanations for why we deviate? I mentioned this as we were talking with you yesterday, and you spoke about how a lot of people admitted to these hospitals were admitted with things like high blood pressure and obesity and things like that.
Well, so I'll give you, let me try and put it to you this way. I think measuring hospitalization is right. I think measuring outcomes becomes very tricky. And my example would be this. In the Eastern Cape, 27% of people, of COVID-19 admitted patients, 27% to public hospitals died. Now, if you just read that line, there would be a national outcry. There would be an absolute outcry. There are hospitals where 60% of the patients admitted have died. There are hospitals in this country where that is a true fact. We have analyzed the data from 591 hospitals, admissions, deaths, and what I can say to you is this: you cannot have a medical facility that incompetent that 60% of the people admitted with COVID-19 die. What you can do is be a little bit more sensible and say, yes, they tested positive for COVID-19, but they obviously went into hospital terminally ill with some other comorbidity or multiple other comorbidities, and COVID-19 just happened to be, so these are people who died with COVID-19, not people who died from COVID-19. If you're going to argue it the other way around, then we should be having the most intensive investigation into our medical facilities you have ever seen in your life, because across the 591 hospitals that I've analyzed, the death rate is currently 17%. COVID does not kill 17%. Nowhere in the world. So this idea, this concept, again, how are we describing a death? In South Africa, we're describing a death from anything. If you've tested positive for COVID, you become a COVID stat. Even if you drove your car into a wall, you are now part of the COVID stat.
I got a question here. Based on Discovery's estimate of the actual deaths and their assumption that the IFR is 0.3 to 0.4%, they estimate that the actual number of cases is 13 million. How many actual cases do you think there have been? And perhaps this is a good opportunity just to talk about the virus SARS-CoV-2 when you test positive for having that virus versus the disease that it creates. I think, you know, that's also important for the listeners to understand.
Well, so we're testing for SARS-CoV-2. That's what the test is for. SARS-CoV-2 is a virus. And testing positive for SARS-CoV-2 is absolutely no indication that you're going to develop the disease COVID-19. So let's take it out of the COVID-19 context. Any South African listening to this podcast, this webinar, every single one of you have been exposed to TB many thousands of times in your life. And if we did a hypersensitive 30-cycle PCR, by the way, all of our PCRs were being used for TB testing. They've now been repurposed for COVID-19. If I put you through a 35-cycle PCR for TB, I'm pretty sure I'm going to find it. But the disease is not expressed. This is the first time in history that we are conflating a positive test for something with an actual expression of the disease. It doesn't make any sense. This is world first in tomfoolery. We are testing healthy people, totally asymptomatic people. To what outcome? What do we achieve by doing that? So if you're testing someone who has blown through the disease, who's recovered from it and has viral RNA sitting in their bloodstream, what is that telling you? It's not actually telling you anything. And we simply do not have the data of, yes, this particular test reached CT threshold at 20 cycles, this one at 5 cycles, this one at 32 cycles, whatever. So that we could do a real measure of, kind of a viral load across a time spline. We can't do that. The data just is not there.
I've got a question here that's more about perhaps the politics behind this pandemic. And the question is, what has been happening in the science community there that there has not been much critical commentary from mainstream scientists on the approach being taken, including the points you've raised about the PCR issue and the viral load versus viral presence?
I think it's a very good question. I'm afraid that academia's got themselves into a hell of a position now, because politicians around the world have been saying we're relying on the science. And when the whole house of cards comes falling down, the politicians are just going to point straight back at the scientists. So they've put themselves into a hell of a position. It's very interesting to note that worldwide, the scientists that are speaking out are not speaking out from positions of academia. They've been shut down. It's guys who have retired or are self-sufficient or are in their own business, etc., etc. So there are very few currently indentured scientists that are speaking out. They've been closed down. You'll note with our own medical advisory committee, early on in the piece, Shabir Mahdi came out strongly. Shabir came out and he said, lockdown is a mistake. It's already community spread and lockdown is not going to work. Glenda Gray came out. A whole number of people, Loadshow, there have been a number of people that have come out and made statements. What happened? They immediately put in non-disclosure agreements, made them sign NDAs. So you ended up with the only person who was the spokesperson for MAC, Professor Salim Abdul Karim, became the official spokesman. It's true all over the world. It is bizarre, it's scary, it's terrible.
Yeah, I think when we hear some of this sort of news within the politics behind the pandemic and just how things have turned out in South Africa in particular, but I'm sure this has happened in many other countries. That's when it gives you a great deal for concern. I think I don't see any new questions. I'm going to ask Sherwin if you can put up the poll again. We're going to ask the same question and see if anyone has changed their view. So Sherwin, if you're there, could you please put up the poll? Once again, the question, do you think that concerns about a second wave of infections in South Africa are justified? Please vote yes or no. We'll just give everyone about 30 seconds to vote. Okay, I don't see anyone else voting. Sharon, if you want to end the poll and show the results. So we've had quite a large change. 81% of people now say no. And I think prior to beginning, we were about 58% said yes. So Ian McGorian, you've changed a few minds for sure. Perhaps as one last thing, my colleague David has just said he could potentially show that video of the United States, which we couldn't do earlier for technical reasons, just to show the sort of progression of the pandemic throughout the country. Cool.
Yeah, it's 1 minute.
David? Cool. David, if you'd like to share your screen just with that slide, and we can play the video.
Just click on the map, it should start. Yeah, okay, click on it again, you stopped it. So this is essentially just showing you how COVID-19 spread through America. Very much following the Hope-Simpson curve for influenza. Just don't click on it, otherwise it stops.
Yeah, so there we see it moving away from New England and into California, Texas, and Florida, and a lot of the South.
And now we're seeing our third wave in the Midwest.
Okay, interesting. Yeah, I think if it teaches one thing, it's just that just like anything, the United States is such an enormous country, and of course it's going to take a long time to spread over such a large geographical area. Perhaps I'll end with one final question. Do you think it's correct to also have viewed South Africa in this regard? I think South Africa's long past this just due to its size, but I mean, did we see similar patterns with the Western Cape kind of beginning and the rest of the country following after that?
Yeah, I think, it was sort of Western Cape well ahead of the pack. I was actually surprised that it took Gauteng so long to catch up. But then typical spread down into KZN. KZN was late to the party. And obviously the more rural areas have taken a lot longer. So it's a whole combination of factors that contribute to this. it's absolutely true to say that in any country in the world, it hits the major metropoles first and the rural areas much later. That's the reality, and you're seeing that here on your American map.
Well, I think we'll end off with that. Thank you very much, Ian McGorian, for sharing. I think there's certainly some valuable information, and a lot of these things, are not being spoken out on the mainstream media. Certainly, a lot of this is very heavy science and not exactly accessible for a lot of people. But I think it's very, very interesting to learn, especially about the PCR testing. The next time anyone here goes out for a PCR test for COVID, why not ask them how many cycles they're going to do, or at how many cycles you tested positive. So just to let everyone know, this briefing will be available on the Centre for Risk Analysis website behind the paywall. It is being recorded. Ian, if we'd like to access PANDA, where can we find them?
pandata.org.za.
Cool. Well, thank you very much, everyone, for attending today's briefing. Thank you very much again to Ian for sharing some very valuable insight. And we'll see you at the next Centre for Risk Analysis briefing. So have a good day, everyone.